In this presentation, we will discuss the importance of early detection and management of immune-related adverse events to assess response to immuno-oncology treatments. Apply recommendations from the 2018 ASCO NCCN guidelines. Management of immune-related adverse events in patients treated with immune checkpoint inhibitor therapy, the testing, reporting and management of patients with immune-related adverse events. We'll begin the module with an overview of immune-related adverse events and then cover cases on immune-related pneumonitis, colitis, hepatitis, hypophysitis, and thyroiditis, and immune-related adverse events in special populations. Throughout the presentation, you'll hear from Dr. Naidu, an oncologist, Dr. Nishino, a pulmonologist, and myself, a pathologist, as we share our thoughts and approaches to these cases as appropriate to our specialties. Immunotherapy drugs actually modulate the immune system, which needs an activated T-cell mediated destruction of tumor cell antigens with a balanced response of immune checkpoint activation, which if there's a balanced response, then there will be no collateral damage to normal tissues. Immune-related adverse events occur when there is an imbalance between the T-cell mediated destruction of the tumor cells, which is required for the immune checkpoint inhibitors to actually destroy the tumor cells, and an immune checkpoint blockade. When there's an imbalance between the two, there is significant collateral damage to normal tissues. So which organs are actually affected by immune-related adverse events? Immune-related adverse events can affect a variety of organs in the human body. The organs that can be involved are eye, where the side effects are uveitis and episcleritis. In skin, the manifestations are pruritus, rash, vitiligo, and alopecia. In the heart, myocarditis, heart failure, and cardiomyopathy have been reported. In the lungs, pneumonitis is a very common immune-related adverse event. In the liver, there is increased liver-associated enzymes that have been reported secondary to immune checkpoint inhibitor therapy. The endocrine system manifests as hypopituitarism, hypophysitis, hypo and hyperthyroidism, and adrenal insufficiency. In the pancreas, pancreatic enzyme insufficiency has been reported. In the kidneys, nephritis, renal failure have been reported. In the gastrointestinal tract, diarrhea, enterocolitis, bowel perforations, and nausea have been reported. And lastly, general manifestations of immune-related adverse events include fatigue, headache, arthralgias, myositis, and decreased appetite. So what are the common terminology criteria for immune-related adverse events? Grade 1 adverse events are asymptomatic or only have mild symptoms. These are associated with clinical or diagnostic observations only, at which point no intervention is generally indicated. Grade 2 immune-related adverse events are considered to be moderate, in which minimal local or non-invasive intervention is generally indicated, and there is limiting of age-appropriated instrumental activities of daily living. Grade 3 immune-related adverse events are considered to be severe or medically significant, but not immediately life-threatening. Generally, the patients require hospitalization or prolongation of hospitalization is indicated if they are already in the hospital. These are considered to be disabling and generally limit self-care activities of daily living. Grade 4 immune-related adverse events are generally life-threatening, and urgent intervention is indicated for these patients. And lastly, grade 5 immune-related adverse events result in death secondary to an adverse event. Now I will turn to Dr. Naidu for an oncology perspective.
Firstly, there are some general principles when it comes to the management of immune-related toxicity. First of all, to always suspect an autoimmune toxicity and include an autoimmune toxicity in one's differential diagnosis. Second, to make sure to rule out common competing diagnoses that may be common to patients with cancers, such as intercurrent infections or progression of the patient's known cancer. Next, it is important to identify the suspected toxicity. For example, to distinguish between diarrhea and colitis, which may imply a different diagnostic evaluation and a more tailored management approach. Lastly, it is important to grade the toxicity, which means to assess the severity of the toxicity according to a set standard guideline, such as the CTCAE guidelines, which stands for Common Toxicity Criteria for Adverse Events. The management of immune-related toxicities is stratified according to the severity of those toxicities. Broadly, a grade 1 toxicity is defined as a mild toxicity which can be managed with supportive care with or without drug withholding. Grade 2 toxicities in general are those that lead to symptoms developed by the patient but do not require hospitalization. In these instances, in most cases, the immunotherapy agent will be held, and one would consider treatment with low-dose corticosteroids, which are given at a dose of prednisone 0.5 to 1 milligram per kilogram per day, or the equivalent. These corticosteroids are usually continued for a number of days until the toxicity improves to grade 1 or less. And in a standard fashion, it is usually continued and tapered over 4 to 6 weeks. Importantly, an exception to this is most endocrine toxicities, which may be treated with hormone replacement alone and may not require corticosteroid therapy. More high-grade toxicities, defined as grade 3 or greater, usually require hospitalization. Again, an exception to this may be selected endocrine toxicities. In these cases, the offending drug is usually discontinued, and treatment with high-dose corticosteroids, defined as prednisone or methylprednisolone of 1 to 2 milligrams per kilogram per day or the equivalent, is commenced, and usually again tapered over approximately 4 to 6 weeks once the toxicity resolves to grade 1 or less.
Dr. Nishino, do you have anything else you would like to add?
So as many of you are aware, cancer immunotherapy using immune checkpoint blockade has really become a major option for treatment of a wide variety of advanced cancers. And one unique thing is that anti-cancer mechanism of immune checkpoint inhibitors is via blockade of immune inhibition by tumors. And because of this unique mechanism of action, a wide spectrum of immune-related toxicities has been reported during immune checkpoint inhibitor therapy, really involving various organs from head to toe. And imaging has an important role in detecting, diagnosing, and monitoring many of these toxicities involving major organs from head to toe as shown here. and we'll discuss some of the major toxicities, including pneumonitis, hepatitis, and colitis in the subsequent part of this talk.
From here, this takes us to our first case, which is of a 40-year-old woman with stage 4 non-small cell lung cancer who receives treatment with 4 doses of the anti-PD-1 drug pembrolizumab and then subsequently complains of cough and shortness of breath. She undergoes a contrast-enhanced CT scan of the chest, which demonstrates the presence of new left-sided infiltrates and air bronchograms.
So the answer for case 1 is C. Hold pembrolizumab, treat with corticosteroids with or without empiric antibiotics, consider hospitalization, pulmonary or infectious diseases consult, and bronchoscopy. The reason for this is because this particular patient has symptomatic pneumonitis. It can be difficult initially to be able to discern between pneumonitis and bronchopulmonary pneumonia. Therefore, certain practitioners would err on the side of treating with both corticosteroids and empiric antibiotics. In order to truly discern between pneumonitis and bacterial pneumonia, usually providers will complete a standard infectious diagnostic evaluation, and this may sometimes include bronchoscopy. The ability to do a bronchoscopy with bronchoalveolar lavage to truly rule out the presence of infection is dependent on an institution's ability to obtain a bronchoscopy within the first 24 to 48 hours of admission. Since this can be clinically challenging, it would be appropriate to treat with both corticosteroids and empiric antibiotics if there is a question as to whether the patient indeed has pneumonitis or bacterial pneumonia. In a patient who has symptomatic pneumonitis, it is appropriate to hold pembrolizumab, since continued pembrolizumab dosing may worsen pneumonitis and its outcomes. The standard management for symptomatic pneumonitis, defined as grade 2 or greater, is corticosteroids, and the dose would be 0.5 to 1 milligram per kilogram per day of prednisone or its equivalent if the patient has grade 2 pneumonitis, or higher at 1 to 2 milligrams per kilogram per day if the patient has grade 3 pneumonitis. The role of pulmonary and infectious diseases consults would be to assist the treating provider in discerning between pneumonitis and pulmonary infection. In those patients who are symptomatic, hospitalization may be indicated depending on the respiratory status of that patient.
Here we see the image of the patient in case 1, and it really relays to us the clinical conundrum of how we diagnose pneumonitis. For in this instance, it may be challenging to discern between the appearances of infection, malignant progression, or pneumonitis in the context of immunotherapy. Given this, a number of diagnostic algorithms and management algorithms have been developed to help to guide the clinician in the standard diagnostic evaluation and management required for patients with suspected or confirmed immune-related pneumonitis. This is one of the first algorithms that was developed, but subsequently there are published algorithms across a number of oncologic societies, such as the National Cancer Control Network, the American Society of Clinical Oncology, the European Society of Clinical Oncology, and the Society for Immunotherapy and Cancer. In this particular algorithm, we see that patients with grade 1 pneumonitis are asymptomatic and may demonstrate radiographic changes consistent with pneumonitis only. In these patients, chest CT scan is appropriate. Microbial assessment may be appropriate to rule out common infections. In most cases, we may continue immunotherapy, but in selected cases, it can be withheld, and symptoms should be monitored for usually every 3 days. A repeat CT scan is usually indicated at some point in the future, but at least with every cycle of immunotherapy. In patients with more symptomatic toxicity, that is, grade 2 pneumonitis, these patients develop mild or moderate symptoms such as cough, shortness of breath, or less commonly, fever and chest pain. In these patients, once again, radiologic imaging with chest CT scans are important, as well as a standard institutional microbial assessment to rule out intercurrent infection. In these cases, one would have a low bar for consulting pulmonary medicine or infectious diseases in order to tailor one's approach to ruling out microbial infection and assess for the possible utility of a bronchoscopy with bronchoalveolar lavage. In these cases, we would withhold immunotherapy, and when there is a high suspicion for immune-related toxicity, treat with prednisone 1 milligram per kilogram per day. Again, in those with more severe toxicity, defined as grade 3 or greater, a high-resolution CT scan is appropriate. Again, the standard microbial assessment, and in these cases, consultation with pulmonary medicine and infectious diseases would be standard. Patients would usually discontinue immunotherapy and require hospitalization, require higher doses of intravenous corticosteroids, and of course, prophylactic antibiotics in case this could represent severe pneumonia. In patients who do not improve, usually after 48 to 72 hours of high-dose corticosteroids, we would usually consider the addition of additional immunosuppression, such as infliximab, mycophenolate mofetil, or intravenous immunoglobulin, and the choice of this is currently debated.
Now I would like to turn to Dr. Nishino for a radiology perspective.
When we think about pneumonitis from cancer immunotherapy, it is important to step back and think about drug-related pneumonitis in general. And when we're looking at imaging of these pneumonitis cases, it is important to note that what we are looking at is lungs response to injury. And injury can be due to cytotoxic effects, oxidative stress, and/or immune-mediated injuries. And because this is a lung response to injury, the response patterns have several types of histopathologic manifestations that have corresponding radiographic patterns. And our prior work have shown that we are able to categorize pneumonitis according to the radiographic patterns corresponding to ATS-ERS classifications of idiopathic interstitial pneumonias and its related disorders as shown here. And many of the pathology colleagues, these terminology and patterns are perhaps something that is familiar to you. But it is also important to note that we are not referring to the histologic pattern by itself, but we are looking at the imaging patterns, what we see on CT scans that are often noted in the setting of these idiopathic interstitial pneumonias, which have these histologic patterns. So this is basically an imaging-based pattern, not really talking about histology. And many of the prior studies from our group and others on pneumonitis from molecular targeting therapy and cancer immunotherapy have used this approach to characterize and classify pneumonitis from these agents. And we review CT scans to define these radiographic patterns of pneumonitis, focusing on extent of abnormalities and distribution, which is the most important factor to define these patterns. And distribution can be diffuse, multifocal, or focal, or can also be peripheral or central. We do look at specific findings or individual findings on CT as listed here, but it is important to note that it is rather how each findings are distributed rather than these individual findings that defines a pattern. It's really the distribution that defines a pattern. And constellation of the assessment of imaging findings, we are able to classify pneumonitis according to radiographic patterns as listed here. Now we move on to the specific findings of ICI-related pneumonitis, which is relatively rare but clinically serious and potentially life-threatening toxicity. The incidence rates from prior meta-analysis about 3% in PD-1 monotherapy trials, and the incidence is much higher in combination trials, up to 6.6%. And more recent meta-analysis also have shown that pneumonitis is a leading cause of anti-PD-1 and PD-L1 related death, accounting for more than 1/3 of the cases. So it is really a clinically serious problem. And our group looked at spectrum of imaging findings in earlier cases of pneumonitis from trials and also in the clinical setting, and have noted that there is a wide spectrum of imaging findings that is almost encompassing the entire spectrum of radiographic manifestations with corresponding clinical patterns. So from here, I would like to show you some of the examples and demonstrate the features of immune-related pneumonitis. So this is a case of immune checkpoint inhibitor-related pneumonitis presenting a pattern what we call AIPIARDS pattern. Some groups like to call this DAD pattern, diffuse alveolar damage, but we chose this terminology based on the classification of ATS and ERS rather than using DAD, which is a pure histology term. So this patient with advanced melanoma at 15 weeks of nivolumab therapy had a severe shortness of breath, and CT scan shows this diffuse granular opacity in both lungs, and bilaterally she developed traction bronchiectasis, and notably on coronal images, the lung volumes are significantly decreased. These are the hallmarks of AIPARDS pattern, and this is the most severe pattern of ICI pneumonitis. These are the ones that lead to death. This patient's symptoms was very severe and needed to admitted to MICU and need intubation and received immunosuppression on top of corticosteroids. So these are the most important patterns to recognize because it has to be diagnosed accurately and treated quickly. However, in some patients, the pneumonitis can be very mild, as in this case showing NSIP pattern. So this another patient of melanoma treated with nivolumab at 7 weeks of therapy. CT scan shows these mild ground glass opacities and interorbital septal thickening predominantly in the peripheral portion of the lungs. The symptom is also mild, and this patient treated with oral corticosteroids on outpatient basis and was able to restart nivolumab therapy and complete the entire 2 course of therapy and remain progression-free and pneumonitis-free. So in some patients, this is how mild this pneumonitis is. As we accumulate our experiences in ICI-related pneumonitis in trials in the clinical setting, we noted that the most common radiographic pattern is what we call a COP pattern. And this is a patient with lung cancer treated with nivolumab. At 15 weeks of therapy, the patient had cough and shortness of breath, but no fever. CT scan showed bilateral, multifocal, consolidative opacities in peripheral and somewhat basilar distribution. And this is the hallmark of this COP pattern. But of course, the differential diagnosis here is infectious pneumonia, and for that, you do need a dialogue with clinical provider to exclude the possibility of infectious pneumonia. And in this case, based on the imaging and clinical findings, the diagnosis of ICI-related pneumonitis was made, and patient was treated with prednisone, and after 4 weeks, CT scan showed marked decrease of these consolidative opacities, showing a good response to prednisone. Another pattern is HP pattern, or hypersensitive pneumonitis pattern, where you see those bilateral ground glass opacities that are often centrilobular distribution, which may be accompanied by air trapping. So we have evaluated 20 patients who developed pneumonitis among 170 patients treated with nivolumab back in 2016. And we found that a COP pattern was the most common pattern. And importantly, AIPARDS pattern had the highest grade by toxicity grade of pneumonitis, followed by a COP pattern, while NSIP pattern and HP pattern had lower grade. So this indicates that radiographic pattern-based approach and subgrouping these pneumonitis based on CT scan can help to guide patient management because it indicates the clinical severity. Most patients received corticosteroids, and 3 also required infliximab as a treatment. Notably, recurrent pneumonitis after rechallenge of immunotherapy and also pneumonitis flare after steroid taper are noted. So I'll show you some of the cases that demonstrate the complexity of this entity. So this is a patient with lymphoma treated with nivolumab and ipilimumab combination therapy. At 1.4 months of therapy, the patient developed these bilateral, relatively subtle but multifocal ground glass opacities and some consolidation, predominantly in centrilobular distribution, still falling into a spectrum of a COP pattern. Diagnosis of pneumonitis was made and patient was treated with prednisone, and at 1.5 months after starting prednisone, most of the abnormalities have disappeared. Because pneumonitis responded well to prednisone, this nivolumab and ipilimumab therapy followed by nivolumab maintenance was resumed, and 2 months after restarting therapy, the patient developed this bilateral, more extensive consolidative opacities in multifocal distribution in both lungs, which is a recurrent pneumonitis due to restart of immunotherapy, again showing a COP pattern, but it's more extensive. The patient was again treated with prednisone, and after 1.5 weeks after restarting prednisone, majority of the abnormalities have decreased, showing good response to steroids. Patients didn't restart any systemic therapy again. However, because pneumonitis responded well, corticosteroid therapy has been tapered, and 1 month after completing prednisone taper without starting any immunotherapy or any other systemic therapy for cancer, the patient developed this multifocal consolidations again, showing a COP pattern more extensive than before. And this is a pneumonitis flare where the immunotherapy pneumonitis come back after stopping steroids without any additional stimulus. And prednisone was given again, and patient responded very well. And again, because of the good response to steroids, this prednisone was tapered, and 2 weeks after completing prednisone taper without starting any therapy, the patient again developed this bilateral multifocal consolidations in both lungs, again a COP pattern of pneumonitis. This is a second episode of pneumonitis flare. In these earlier cases of our experience, transbronchial biopsy was performed at this point, showing organizing pneumonia, confirming our observation and imaging. So this is how complex this entity can be in some patients. Now, we do have emerging issues and diagnostic challenges as the cancer immunotherapy using immune checkpoint inhibitor evolve in clinical oncology. And I'd like to point out 2 issues. The first one is EGFR tyrosine kinase inhibitor pneumonitis in patients who are treated with immune checkpoint inhibitors. And the first report came in that 8 advanced non-small cell lung cancer patients in Japan who were previously treated with nivolumab developed severe interstitial lung disease, or pneumonitis more precisely, during subsequent treatment using EGFR TKI, leading to 3 deaths. So this indicated a possibility of rather severe consequence of combination or sequence therapy of EGFR TKI in combination with immune checkpoint inhibitors. In a more recent study of 20,000 non-small cell lung cancer patients, higher odds of developing EGFR TKI pneumonitis was shown in the group who have been treated with nivolumab. Another issue is pneumonitis related to consolidation immune checkpoint inhibitor therapy using nivolumab after chemoradiotherapy for stage 3 non-small cell lung cancer, which is an approved therapy by US FDA. And in this trial, more than 1/3 of the patients with nivolumab arm have developed pneumonitis, which is higher than the placebo group. But of course, there's a combination of radiation pneumonitis and immune checkpoint inhibitor pneumonitis, or combination of both, so further studies are needed. And I'd like to just show you an example of pneumonitis who are treated with a combination of radiotherapy and immunotherapy from our recent publication. This is a melanoma patient treated with right axillary radiation followed by nivolumab. At 2 months of therapy, the patient presented with cough and shortness of breath, so clinically pneumonitis, and CT scan at this time showed this consolidation in the periphery of the right lung corresponding to the radiation field, but there is a focus of ground glass opacities pointed out by a white arrow that is beyond the radiation field. Follow-up CT 2 months after holding nivolumab and starting corticosteroids showed resolution of these right upper lobe opacities. However, a new focal peripheral opacity was noted, which is also outside of the irradiated lung. And further follow-up CT taken 1.5 months later showed resolving opacity with additional new foci of peripheral consolidations both outside of the radiation field and also within the irradiated lung. So the investigations are still going on, and knowledge is still kind of limited and evolving for this complicated entity, but it is important to pay attention to pneumonitis from combination radiotherapy and immune checkpoint inhibitor therapy, because this approach is expanding and increasingly tested in trials and used in the clinical setting.
In conclusion, awareness of characteristic imaging findings and radiographic patterns of immunotherapy-related pneumonitis contributes to accurate diagnosis and optimal patient management. Multidisciplinary approach is essential to further understand this entity and address emerging challenges.
This brings us on to our next case, and this is of a 51-year-old man with stage 4 metastatic melanoma. In this case, the patient received 3 doses of the anti-CTLA-4 medication ipilimumab and complained of new onset diarrhea. This was defined as increased stool output with 7 to 8 stools per day and 1 episode of incontinence. The patient also noticed mild abdominal discomfort, however, no blood in the stool and no fevers.
In this case, the answer is F, meaning that this patient should discontinue ipilimumab. Stool cultures, including ovoparasites and C. difficile, should be checked. One should consider a GI consult for completion of a colonoscopy or sigmoidoscopy with colon biopsies and rapid review, to start systemic corticosteroids, as well as consider IV fluids, and to consider a CT abdomen and check a quantiferon gold. So this is the standard diagnostic evaluation or workup for a patient who is presenting with clinical symptoms concerning for severe diarrhea or colitis from ipilimumab. In this case, the patient has both diarrhea and abdominal discomfort, therefore raising the question as to whether the patient has developed symptomatic colitis. In this instance, it is important to hold the offending immunotherapy, option A, to check for alternative diagnoses such as GI infection, option B, to consider a colonoscopy or sigmoidoscopy for pathologic confirmation of this toxicity, option C, to start empiric treatment with corticosteroids and supportive treatment with IV fluids, option D, and to consider a CT abdomen as the patient has abdominal discomfort. This would be to rule out a perforation, and to check a quantiferon gold in case the patient's clinical symptoms worsen in the next 48 hours and they require infliximab therapy. Therefore, overall, the answer is answer F, all of the above.
The patient underwent a colonoscopy and demonstrated some colonoscopic evidence of classic autoimmune colitis. For example, the demonstration of multiple shallow ulcers with the presence of exudates and ulcers also in the transverse colon. It is important, as noted in this slide, to inform the pathologist of the clinical scenario, as these appearances may represent a number of other items on the differential diagnosis, and the recent treatment with ipilimumab may help to hone this. Again, as we stipulated in the original slides, it is important to grade this toxicity according to the CTCAE. And according to the severity toxicity scale, we see that this patient is presenting with grade 3 colitis, with an increase in stools of greater than or equal to 7 a day, incontinence, and hospitalization required. In view of the presence of abdominal pain, one would also think about doing a CT scan of the abdomen in order to distinguish between colitis and diarrhea. Again, we see here that it is important to assess the severity not only by the number of stools per day, but also by clinical symptoms such as cramping, fever, malaise, or blood in the stool.
Dr. Schroff, what are your thoughts on this?
The most common adverse events are associated with immune checkpoint inhibitor for anti-CTLA-4 receptor, such as ipilimumab, which include diarrhea and colitis in about 30% of patients, and abdominal pain in approximately 15% of patients. The anti-PD-1 agents, such as pembrolizumab and nivolumab, induce diarrhea in a lower proportion of patients, about 6 to 16% of the patients receiving this therapy. Combination therapies are being used for anti-CTLA-4 and anti-PD-1 agents, and in these patients, intestinal perforations have rarely been reported. So what are the patterns of injury in the GI tract for immune checkpoint-mediated enterocolitides? The patterns of injuries are varied, and immune checkpoint inhibitor immune-related adverse events are a great mimicker of other well-known enterocolitides. The GI tract is one of the most common locations for biopsy because of its easy access to the various organs within the GI tract. So the patterns of injury that are most commonly reported are lymphocytic colitis-like pattern of injury, a microscopic colitis-like pattern of injury, idiopathic inflammatory bowel disease-like pattern of injury, an infectious enterocolitis-like pattern of injury, an ischemic bowel-like pattern of injury, and a gluten sensitivity enteropathy-like pattern of injury involving the upper GI tract. Here is an example of a lymphocytic colitis-like pattern of injury, wherein if we look carefully at the surface epithelium, we see a greater number of intraepithelial lymphocytes within the colonic mucosa. There is also expansion of the lamina propria as observed in these histologic images. Collagenous colitis pattern of injury has also been reported in patients with immune-related adverse events in the GI tract. In this pattern of injury, patients will show a significant subepithelial collagen deposition in the colonic mucosa, either on the right or on the left colon. So here is an example highlighted by the green arrows wherein you can see a thick subepithelial collagen band, associated surface epithelial colonic injury highlighted by the red arrows. Here are additional images of a collagenous colitis pattern of injury that is seen within the colonic mucosa. There is subsurface epithelial injury, as was seen in the previous slide, with associated thick subepithelial collagen band deposition. But the other interesting finding, or the unique finding that we see in checkpoint-mediated colitis, is the presence of numerous crypt epithelial apoptoses that we don't see in routine collagenous colitis. Unlike what is routinely seen in patients with lymphocytic colitis and collagenous colitis in clinical practice, which the patients generally present with watery diarrhea, and endoscopic findings show an uninvolved colonic mucosa. In patients with immune checkpoint inhibitor mediated collagenous colitis or lymphocytic colitis, generally the colonic mucosa shows inflammation and endoscopic changes, which are then subsequently biopsied, giving these patterns of injury. So even though there is a histologic mimicking of the enterocolitic pattern of injury with collagenous colitis and lymphocytic colitis, endoscopically the appearance is completely different. Here's another example of increased epithelial apoptoses with associated expansion of lamina propria in a patient who had received immune checkpoint inhibitor therapy. The next pattern of injury that has been observed in recurrent or long-standing immune checkpoint mediated injury is an idiopathic inflammatory bowel disease-like pattern of injury. In this pattern of injury, features of chronicity that we normally observe in long-standing idiopathic inflammatory bowel disease, such as crypt architectural distortion, highlighted by the 3 yellow circles, is visible. In addition, we can even see crypt liftoff and expansion of the lamina propria. In the left colon, sometimes we observe colonic Paneth cell metaplasia in patients who have recurrent immune checkpoint mediated colitis. The unique feature, however, as I described earlier, has been presence of numerous crypt epithelial apoptoses, even in patients who have an idiopathic inflammatory bowel disease-like pattern of injury. Now, increased crypt epithelial apoptoses are a routine feature of IBD in the colonic mucosa. However, the crypt epithelial apoptoses that can be seen with immune checkpoint inhibitor pattern of injury may be far greater than what is seen in ulcerative colitis or Crohn's disease. Additional patterns of injury on a gross appearance include deep ulceration and fissuring of the colonic mucosa, submucosa. Transmural perforations have been reported as well, especially with combination therapies. Histologically, we notice expansion of lamina propria by both acute and chronic inflammatory cells, such as lymphocytes, plasma cells, and neutrophils. And very rarely, granuloma formation has also been noted in patients with immune checkpoint inhibitor mediated colonic injury. One of the not very frequently observed patterns of injury is an ischemic colitis-like pattern of injury, where we typically see withering of the surface crypts and hyalinization of the lamina propria, as is noted in this example. Patterns of injury in the upper gastrointestinal tract include inflammation and apoptosis of the esophageal mucosa, rarely, gastric mucosa, and also in the duodenum. Here is an example of duodenal villus blunting in the duodenal bulb in a patient with a history of pembrolizumab therapy, which is mimicking gluten-sensitive enteropathy. In this image, we can see increased intraepithelial lymphocytes, which is mimicking gluten-sensitive enteropathy in a patient who has received immune checkpoint inhibitor therapy. Furthermore, what we can observe in these patients are cryptepithelial apoptoses within the small intestinal mucosa with marked expansion of lamina propria, as well as neutrophilic debris in the luminal aspects of the small intestinal mucosa. Dr. Nishino, what are your thoughts on this?
So immune-related colitis is one of the most common irAEs, especially during ipilimumab therapy. And radiographically, 2 radiographic patterns are reported, including diffuse colitis pattern, as you can see on this slide, where the colon is dilated and fluid-filled, and it tends to involve a long segment or sometimes even entire colon. Another pattern is segmental colitis associated with diverticulosis, or SCAD pattern, reported from the Dana-Farber group, where you can see those underlying diverticulosis and inflammatory changes in the area of underlying diverticulosis with peripheral stranding and wall thickening, just like you see in the setting of diverticulitis, but this is another pattern that is seen less frequently. And these cases are treated With steroids, with and without antibiotics, and diffuse colitis pattern tend to receive steroids alone, while SCAD pattern tend to also receive antibiotics.
This brings us to our next case. And this is a patient with a 68-year-old gentleman with stage 4 MSI high colon cancer who had received 4 doses of pembrolizumab and sustains a tumor response, but also incontinence. The patient unfortunately demonstrated increase in liver function tests with an AST and ALT of 7 times the upper limit of normal and a normal bilirubin.
For case 3, the answer is E, which includes both options B and options D. So option B includes consideration of a liver ultrasound, and D, a recommendation to start systemic corticosteroids at a dose of 1 to 2 milligrams per kilogram per day of prednisone or the equivalent. In this case, the diagnosis is likely to include immune-related hepatitis, or it is important to rule out alternative diagnoses. In this case, the patient's liver function tests with AST and ALT are 7 times the upper limit of normal. This usually indicates that the patient has a symptomatic hepatitis. In order to rule out alternative diagnoses, such as metastatic disease in the liver, a liver ultrasound is usually the first radiologic investigation that we would recommend. Empiric treatment for immune-related hepatitis would be systemic corticosteroids, which is option D. Therefore, the answer is E, B, and D.
This is a typical case of immune-related hepatitis, and it is an example of a patient presenting with grade 2 AST or ALT elevations. In these cases, it would be routine to consider an ultrasound of the liver to rule out the presence of liver metastasis. It is important to note that most elevations of AST and ALT are asymptomatic in patients, and that this is more common from the CTLA-4 monoclonal antibody at 10%, but occurs in less than 5% of cases with PD-1 or PD-L1 monoclonal antibodies alone. Importantly, high-grade events may occur in 1 to 2% of cases, and there may be an increase in this particular toxicity with certain immunotherapy combinations, such as the combination of BRAF inhibitor with immunotherapy. In terms of management, it is important to explain to a patient to minimize alcohol intake and to institute an oral corticosteroid taper of at least 3 weeks. Importantly, for many steroid-refractory immune-related adverse events, the go-to immunosuppressive agent after corticosteroids is infliximab. However, for immune-related hepatitis, there is an FDA black box warning us to not treat with infliximab, as this may cause its own hepatitis. Therefore, for these patients, we would routinely treat with mycophenolate mofetil if corticosteroid taper alone is not sufficient to manage this toxicity.
Now I would like to turn to Dr. Schroff for a pathology perspective.
The immune checkpoint mediators can also cause significant liver injury and cause immune checkpoint-related hepatitis. Immune checkpoint-related hepatitis is less frequently encountered in terms of biopsy specimens compared to the injury of the luminal GI tract because it is less easily accessible. The most common clinical manifestation of immune checkpoint-mediated hepatitis is asymptomatic elevations of liver-associated enzymes or liver function tests, such as elevation of AST, ALT, and mild elevations in total bilirubin. The patterns of hepatitic injury similar to the luminal GI tract, are highly variable and can show different patterns of injury. The most common pattern of injury that is observed is an active panlobular hepatitis, in which mixed inflammatory infiltrate is noted in the lobular as well as the portal parenchyma. The mixed inflammatory infiltrate consists predominantly of lymphocytes along with numerous lobular macrophages loosely arranged in the form of microgranulomas. As opposed to autoimmune hepatitis, plasma cells are a rare finding in this pattern of injury secondary to immune checkpoint mediated inhibitors. Numerous apoptotic hepatocytes can be observed within the lobular parenchyma, which correspond to the elevations in AST and ALT that are seen clinically. Rare cases have been observed with fibrin ring granulomas. The next pattern of injury that has been frequently reported in hepatitic injury secondary to immune checkpoint inhibitors is confined to the zone 3 parenchyma. The findings are similar, comprising a mixed inflammatory infiltrate consisting predominantly of lymphocytes, but then there's also association of the perivenular inflammatory infiltrate and collapse of the perivenular hepatic parenchyma. The next pattern of injury is a biliary orocholangiopathic pattern of injury. This pattern of injury is not as frequent as the first two patterns of injury described here. However, is composed of a portal mononuclear inflammatory infiltrate around foci of bile ductular proliferation. Other patterns of injury that have been described are a mixed neutrophil-rich, predominantly portal inflammatory infiltrate with foci of acute cholangitis. And lastly, not very commonly reported, is a steatohepatitic pattern of injury. It is rare and may represent exacerbation of underlying fatty liver disease. Here is an example of a mild panlobular hepatitis, wherein we can see dense portal inflammatory infiltrates, which are a mixed inflammatory infiltrate associated with lobular activity in the form of loose microgranulomas or collections of histiocytes, as can be observed in this low power magnification. On higher magnification, we can occasionally see portal and lobular mixed inflammatory infiltrate, which may be robust with associated hepatic injury and focal endothelial inflammation, as is highlighted by the red arrow. Numerous lobular macrophages in aggregates or microgranulomas are observed in this example with lobular inflammation. Here is a high magnification image showing numerous lobular macrophages in aggregates with associated hepatocellular dropout. These are microgranulomas in the zone 3 parenchyma, as can be seen around the central vein right here. The other pattern of injury that has been seen are mixed inflammatory infiltrate in the portal tracts, which are the inflammatory infiltrate consists predominantly of mononuclear cells such as lymphocytes and also scattered histiocytes. And in this picture, what we are able to see are lobular microgranulomas with associated steatosis in the lobular parenchyma. Fibrin ring granulomas have rarely been observed in the setting of immune checkpoint mediated injury. Here is an example of an H&E stain slide showing a lipid vacuole with surrounding histiocytes and mononuclear inflammatory cells highlighted by the red arrow. The fibrin ring granulomas are best highlighted on a trichrome stain. The fibrin ring granulomas consist of a central lipid vacuole surrounded by histiocytes, a ring of fibrin, and an outer layer of histiocytes again. The other pattern of injury that has been observed is a zone 3 hepatitis and a dense perivenular inflammatory infiltrate and collapse. The zone 3 parenchyma shows a dense inflammatory infiltrate highlighted by the red arrows. On high magnification, we can see that there is collapse of the perivenular hepatic parenchyma with hepatocellular dropout and collapse of the perivenular hepatocytes with associated dense mixed inflammatory infiltrate composed of neutrophils and mononuclear cells. One of the rare reported patterns of injury is a biliary/cholangiopathic pattern of injury, as seen by this example over here. The red arrows actually point to the bile ducts, which show significant biliary epithelial injury with lymphocytic infiltrate, with vacuolization, and biliary epithelial dropout. Additionally, the portal tract shows a dense mononuclear inflammatory infiltrate composed of lymphocytes and histiocytes. Note that plasma cells are not a very common inflammatory cell in immune checkpoint mediated injury, though they can be observed. Here is an example of a biliary/cholangiopathic pattern of injury with once again a dense portal mononuclear inflammatory infiltrate with associated bile ductular reaction or bile ductular proliferation. The yellow circle highlights the apoptotic hepatocytes that are present in the vicinity of this portal inflammation. Another pattern of injury that has been observed with regards the biliary epithelial injury is a pattern of acute pericholangitis highlighted by the red arrows with a dense neutrophil-rich portal inflammatory infiltrate. Also noted in this image are apoptotic hepatocytes in the periportal hepatic parenchyma. Dr. Nishino, do you have anything to add?
Immune-related hepatitis has a spectrum of manifestations ranging from severe cases with systemic symptoms and highly elevated liver function tests. In these cases, the CT scan may show hepatomegaly, periportal edema, and periportal lymphadenopathy, as you can see in this case, while some of the cases are mild and asymptomatic with only mildly elevated LFTs, and in these cases, there may be no abnormalities on imaging.
Moving on to our next case, case 4. This is a 67-year-old gentleman with stage 4 metastatic melanoma, and he receives treatment with a combination of ipilimumab and nivolumab, and is then found to develop profound fatigue and headache.
For case 4, the answer is E, consistent with treatment-related fatigue, hypophysitis, or hypothyroidism. In this case, the patient presents with nonspecific symptoms of fatigue and headache. We know that immunotherapy may cause a treatment-related fatigue as a standalone side effect of immunotherapy, and therefore fatigue alone may indeed be a unifying diagnosis for this clinical presentation. However, fatigue may be a symptom of endocrine toxicities such as hypophysitis or hypothyroidism, and in these cases, patients may also develop headache. Therefore, one should also consider the potential diagnoses of hypophysitis or hypothyroidism.
As many oncologists would be aware, fatigue is a very common symptom for patients who have cancers, patients who are treated with systemic therapy, and patients who are in particular treated with immunotherapy. One of the differential diagnoses that is important to consider is the diagnosis of hypophysitis. and many endocrine immune-related adverse events may present clinically with fatigue. This includes hypophysitis, which is inflammation of the pituitary directly linked to lymphocytic infiltration of the pituitary, autoimmune thyroiditis, which may manifest as either hypo or hyperthyroidism, or patients may present with de novo hypothyroidism or hyperthyroidism, or in a small number of cases, primary adrenal insufficiency. In these patients, as I had mentioned, the clinical symptoms may be nonspecific, with fatigue alone, or in the case of hypophysitis, may occur with headache. In these patients, the standard diagnostic evaluation would be a thyroid-stimulating hormone, T4 level, plus or minus a T3 level. And in patients with suspected hypophysitis, an MRI of the pituitary would be indicated. And this is an example of an MRI demonstrating an increase in size of the pituitary gland. In these cases, it would be important to consult one's endocrinology colleagues and to institute appropriate hormonal replacement.
Dr. Nishino, what are your thoughts on this?
So this is a case of immune-related hypophysitis with MR imaging manifestations. This is ipilimumab-associated hypophysitis in a patient with melanoma at 7 weeks of therapy, and contrast-enhanced MRI scan of the sagittal image of the brain shows enlarged pituitary gland and thickening of the stalk, just like you see in the setting of lymphocytic hypophysitis, but in the clinical context of cancer immune checkpoint inhibitor, this is immune-related hypophysitis.
Dr. Naidu, what are your thoughts on this?
In the original studies, it was identified that many patients may develop either hypo or hyperthyroidism from immune checkpoint inhibition. However, more recently, it has been identified that these patients may actually represent a spectrum in which they originally present with hyperthyroidism, but then have a prolonged period of hypothyroidism consistent with thyroiditis. In these patients, they have an initial phase of a leaky thyroid for the first 2 to 6 weeks in duration, and then this is followed by a hypothyroid phase where there is recovery of the depleted gland, and patients will present with the classic symptoms of fatigue, hair and skin changes, fluid retention, and constipation. Originally, it was thought that hypothyroidism would likely be permanent. However, now we are seeing cases that do recover and therefore represent a transient hypothyroidism. So case 5 is an 80-year-old gentleman with stage 4 PD-L1 high non-small cell lung cancer and a known history of rheumatoid arthritis. This patient presents to the oncology clinic for a discussion regarding his treatment options.
The answer is C, which includes options A or B, where A represents pembrolizumab and B represents the option of pembrolizumab plus chemotherapy. So in this particular question, we are asked whether a patient with a known rheumatoid arthritis may be suitable for immunotherapy. While many of these patients may have been excluded from entry into clinical trials for immunotherapy agents, there are several retrospective series that identify that patients with known autoimmune conditions may derive the same level of benefit from immunotherapy, and while they may have a higher risk for experiencing recrudescence of their known autoimmune condition or develop new immune-related toxicities, these are within manageable limits. Therefore, in this case, a patient with stage 4 PD-L1 positive lung cancer, they may indeed receive standard of care with either pembrolizumab or pembrolizumab plus chemotherapy based on published phase 3 data.
This brings up a very important case that we see commonly now in the clinic of patients who have autoimmune conditions or may have sustained prior immune-related adverse events. And these are special populations who would have been excluded from many of the clinical trials of these agents that led to their FDA approval. This has led a number of groups to examine whether patients who have known autoimmune conditions may still demonstrate the same benefit from immunotherapy or may have a higher rate of toxicity. In this paper by Leonardi and colleagues, 56 patients with non-small cell lung cancer and a known history of autoimmune disease were examined. Most of these patients received treatment for non-small cell lung cancer in the second-line setting, where the standard response rate was in the order of 20%. And what we see from this study is that the response rate in patients with autoimmune conditions was similar at 22%. The incidence of a flare of the patient's known autoimmune condition was 23%, with 13% grade 3 or higher toxicities. Importantly, 38% of these patients developed an immune-related adverse event, of which 26% were grade 3 or greater. So substantial toxicity, but not out of the realms of those that have been published in those without autoimmune conditions. So what were the autoimmune conditions that were included in this series? This included rheumatologic, dermatologic, endocrine, GI, neurologic, and other autoimmune conditions. This paper demonstrated that the 6-month cumulative incidence of an autoimmune flare was around 21%, and the 18-month cumulative incidence of a flare was around 23%. Looking specifically at the patients who developed immune-related adverse events, as mentioned, there was a high rate of grade 3 immune-related adverse events. 14% discontinued their PD-1 or PD-L1 inhibitor. 5% had both a flare of their known autoimmune condition and an immune-related adverse event. However, 0% had flares and immune-related adverse events after PD-1 or PD-L1 alone. Importantly, there was no association between the use of baseline steroids and the generation of a response to checkpoint inhibitor, and no association between flare and response. Some open questions which are currently being studied is whether giving these treatments in the context of solid organ transplants and bone marrow transplants is safe. I would now like to highlight, without the support of certain cases, some fatal immune-related adverse events that may occur from immune checkpoint inhibitors, an example of which is myocarditis. So myocarditis is defined as inflammation of the heart muscle and constitutes a fatal toxicity that occurs in approximately 1.2% of patients treated with checkpoint inhibitors, and had the highest ICI-related fatality rate in a large study published in JAMA Oncology recently. Patients with this particular toxicity present most commonly with chest pain and conduction abnormalities. And we have seen that the mechanism of this toxicity is likely to be driven by a generation of T-cell infiltrates in both the heart and the skeletal muscle. In an important study published in the New England Journal of Medicine, we see that the clones that may be expanded in the skeletal muscle and the striated muscle in the heart may actually be similar T-cell clones that are responsible for a tumor infiltration that we concurrently see in the tumor and may actually lead to tumor responses. So some interesting mechanistic data published by the group at Vanderbilt.
Dr. Shroff, do you have anything to add?
Immune checkpoint inhibitor-associated myocarditis is not a very common immune-related adverse event that has been reported in patients receiving immune checkpoint inhibitors. Approximately only 1% of the patients are affected. However, the mortality rate is very high, approximately 15%. Consequently, biopsy specimens are very rare. Two pathologic grades of immune checkpoint inhibitor-associated myocarditis have been reported in a recently published paper. In a high-grade pattern, more than 50 CD3 positive cells per high-power field have been noted in the injured myocardium, and in a low-grade pattern, less than or equal to 50 CD3 positive cells are noted per high-power field. However, it is unclear if these distinct pathologic grades are associated with distinct pathologic outcomes. So here is the pattern of injury for a high-grade immune checkpoint associated myocarditis and a low-grade immune checkpoint associated myocarditis. In the high-grade pattern of injury, what we can see in the left panel is increased number of CD3 positive lymphocytes infiltrating the myocardium and associated myocardial necrosis. In a low-grade pattern, we can see less than 50 CD3 positive cells, as noted in the lower right panel, and minimal myocardial necrosis compared to the high-grade pattern. Dr. Naidu, what are your thoughts on this?
Another potentially fatal toxicity that can occur from checkpoint inhibitors is type 1 diabetes mellitus. Again, this is rare, but can be emergent. And we know that in 50% of cases of patients who develop type 1 diabetes from checkpoint inhibitors, that these patients present in diabetic ketoacidosis. This occurs most commonly more than 3 months after the last infusion of PD-1 or PD-L1 inhibitors, and appears to be more common in those treated with PD-1 as opposed to PD-L1 agents. Across a number of studies, we see that the incidence of this toxicity is exceedingly rare at 0.4 to 2%. The risk factors for the development of this toxicity include that more than 70% of cases are related to certain HLA genotypes, and 50% of cases were associated with the presence of pretreatment antibodies. In terms of diagnosing type 1 diabetes, it is important to distinguish between type 1 and type 2 diabetes, usually taking into account symptom onset, patient treatment with steroids in the past, and the presence of a C-peptide level. It is important, of course, to look for signs of insulin deficiency, ketosis, and acidosis, and to perform an autoantibody screen. In terms of management, it is important to realize that insulin is always right, regardless of which type of diabetes we are treating, and of course to have a low threshold for consulting endocrinology.
In summary, with the increasing use of immune checkpoint inhibitor therapy in the management of advanced malignancies, immune-related adverse events are an increasingly common finding. Numerous organ systems can be involved, and patients should be closely monitored for signs of immune-related adverse events. The presentation can be markedly delayed after initiation of therapy, or it can be even noted after cessation of therapy. Lastly, the gastrointestinal tract and skin lesions are the most common locations for biopsy because of easy access. Histologic features of immune-related adverse events in general are varied and often mimic other disease entities.